Now we're gonna hear Filip Kukulic talking about his clinical experience and with radiation therapy for VT and the ENCORE VT trial.
Great. Good evening, everybody. Thank you very much for this opportunity. On behalf of my colleagues from Washington University in St. Louis, in particular the radiation oncologist that I work with, Cliff Robinson, thanks for this opportunity. Appreciate it. I'm going to summarize our workflow in about 40 seconds for you. So here's our workflow in 40 seconds. The patient wears a non-invasive vest of electrodes to non-invasively map the heart. The patient wears the vest, gets a CT scan done, and we bring them down to the EP lab and induce the VT. Non-invasively, we're able to pinpoint where that VT is coming from. I'll show you some specific data in a moment. We combine that information with anatomic and metabolic information from a PET and an MRI. We use that to describe the area that we need to target. A focused beam of radiation is delivered to that target, and that's done in just about 10 minutes or so at our institution. This is done while the patient is awake. Last year, I believe I showed a video of somebody getting the world's fastest at 7 minutes, and then he gets up and walks off. I wanted to show you some new data today. This is going to form sort of the theme of my talk today is really not what we have done, but what we need to do. So there's much work that really needs to be done. A couple of weeks ago, we hosted a symposium in St. Louis called the Symposium for Non-Invasive Radioablation. We anticipated 40, maybe 50 people who might be interested, and from 15 different countries, we got 180 people, all willing to help, all willing to figure out what we need to do to move this field forward. So there's much work to do, and let's talk about what that formal testing is. We published our first 5, what we call the ENCORE 5, kind of like the Jackson 5. We call the ENCORE 5. We treated these patients in 2015, and I want to show you some longitudinal follow-up from those patients. Turns out that over the course of 2 weeks ago at that symposium, we learned about a number of other centers who have also treated patients in very similar ways, shown here. What was very exciting, although most of that data is not yet published, what is very exciting is that the overall effect was reproduced from center to center, from country to country. So we're very enthusiastic about where this is going. In 2017, we opened up a prospective phase 1, phase 2 trial, not a case series, but a prospective trial to understand the risks as well as the potential for efficacy. These patients were treated in 2017. I'm very excited to say that we're going to present this data as a late breaker at American Heart Association in a month. So we'll talk a little bit about that trial. And then where do we go from here? A prospective multi-center trial has already been put together, and we've been in close collaboration with the FDA in terms of making that an IDE type of trial. And that's going to begin in early 2019. But what we've learned from our patients who've undergone this treatment is that we really need to take it backwards. We need to take it from the bedside back to the bench, because there's a lot about basic mechanism that we don't fully understand. And we've got a lot of data, a wealth of data from serial human imaging, from biomarkers before and after, preclinical models that we're already testing. There's a lot of basic science that we need to understand here. There's a lot on the treatment delivery. You just heard about one method of treatment delivery with its particular management of motion and its use of fiducials. Our way is a bit of a different way in terms of managing motion and without the use of fiducials. And I think the question is appropriate, what is the right dose? When we look at the preclinical models, I think we have an understanding of that, but there's more work to be done there. Perhaps most useful for this group is the idea of how do we non-invasively target VT? How do you actually figure out what the target is for this type of a treatment? And earlier this morning was just a fantastic session about multimodal imaging and understanding the anatomy that went into this. And I think that's really going to inform a lot of what we do. But also we're learning more and more from the invasive mapping, from the great data that we're getting from the EP lab. So I wanted to show this last year, but it was under embargo. So I'm going to show it this year. This was the first 5 patients, our ENCORE 5. These were patients who had no other options. They'd already exhausted endocardial, epicardial when appropriate. They had been on multiple antiarrhythmics. We delivered 25 grain, a single fraction, with a mean ablation time of 14 minutes. Shown here is each of those 5 patients in the month-by-month VT episodes. You can see the number of VT episodes that they had. And then this is after treatment. And importantly, we got 4 of those patients off of antiarrhythmic drug for a while. You can see at month 9, one of those patients had a recurrence. He said, I'll get back on my amio. But the effect is more than just the medicines. It seems to be rather durable. Now, this is probably the reason why Vivek invited me back to talk about this some more. So I want to show you some unpublished data as we followed these patients out now past 3 years, because I think we have to be open about the possibility of harm, and we have to be open about the possibility that there could be VT recurrences. So shown here is the first 12 months, and I want to talk about each one of those individual patients. That first patient was an 84-year-old woman, and she had a stroke about 3 weeks after her treatment. She had a CHADS VASc score of 7. She couldn't take anticoagulants because she'd had brain bleeds. She was in VT storm. She was offered hospice. We gave her this option. We learned a lot from her after she had her fatal stroke. She was generous enough to donate her heart for us to be able to learn. The third patient had a very low ejection fraction, was listed for an LVAD, but they refused giving him an LVAD due to his VT storm. We quieted down his VT storm. He went for an elective LVAD right around 9 months. You see a little red spike right there. That was the perioperative LVAD placement. And he is still alive and hasn't had any more VT. If you look through the next year, we had one patient who had VT storm right around the 14th month. I went back in and invasively mapped him. He had 7 different VTs at that point. He had a non-ischemic cardiomyopathy to begin with. He ultimately went for his heart transplant and is still alive. If you look at the next year, the next 12 months, we had one patient who ultimately went for an LVAD. Again, he had a low ejection fraction at the time of treatment 3 years prior, and he died of postoperative complications. Patient 2 is at the end of that at 39 months now. He's the longest living survivor. He has not had any heart surgeries. He's not had any other VTs off antiarrhythmics. So I don't know, are you a glass half full person or a glass half empty person? Because if you're glass half full, there's a lot of months that go by that sick patients don't have VT. If you're a glass half empty person, you'd say, well, that's a lot of LVADs and heart transplants to be given to 5 patients. And I think the truth is both. I think the truth we have to monitor. These were very sick patients on the front end. We won't know until we randomize or until we think about doing this in less sick patients. So let's talk about that. So the ENCORE VT trial was a single-arm, phase 1, phase 2 prospective trial that we ran at our single center. I want to call out our study coordinator, Caitlin Moore, who's done a phenomenal job. This is a trial that has already closed. Inclusion criteria was rather open. Patients needed to have sustained VT, and generally a lot of it. We said 3 or more sustained VTs. They could also get into the trial with PVC-related cardiomyopathy, that is greater than 20% PVC burden with an EF less than 50%. Patients had to fail at least 1 drug, at least 1 catheter ablation. More commonly, they failed 2 drugs and at least 2 catheter ablations. Exclusion criteria was pretty narrow. That is, we took just about everybody. We excluded you if you had prior radiotherapy. We excluded you if you had heart failure, but severe heart failure, inotropes and LVADs. We took everybody else. If you had a poor non-cardiac prognosis or nasty VT, polymorphic VT, or more than 5 different induced VTs. So let me be clear about that. We took class 4 heart failure patients with non-ischemic cardiomyopathies who have bad kidneys. We took them all. This was the worst of the worst. And like I said, late-breaking clinical trial is going to be AHA in about a month. So I can't share with you the results, but this is what you're going to hear about. You'll hear about our primary safety data and our primary efficacy data. You'll hear about the overall survival at 6 and 12 months, the drug use, antiarrhythmics, and a quality of life score. So we're really excited about this. We look forward to sharing that. And while we spend a lot of time thinking about how to ablate and how to use this, in this room we should actually be thinking about how can we tailor this down. So finding scar is actually easier than finding VT circuits. This is a VT or a MRI from one of our patients. There's the normal, but here's a nearly transmural scar on the inferolateral border. You see a stripe in the midmyocardial border there. You see a patchy scar. What are we going to actually target for ablation here? This is not pure scar homogenization. We'll be ablating 75% of this patient's heart. So which scar is actually critical for today, and what about tomorrow's VT? We had a number of patients who had really large scars. Here's a big anterior septal apical scar. Again, are we going to ablate that entire area for scar homogenization, or will we be more specific about what we're going to do? So we leverage multimodal imaging. We feel very strongly that we can get the electrical information from ECGI and marry that to the anatomic metabolic information as well to really pinpoint the target for us. And I'll just finish with one of the examples. This is a 75-year-old pastor who actually came to our talk 2 weeks ago. He had several catheter ablations, several monomorphic VTs. He had abandoned ICD leads, so he couldn't get an MRI on our protocol. This is what ECGI looked like in sinus rhythm. We see the area of latest activation on the lateral left wall in blue. There's a circle of red there. That was actually the area that we had ablated, both endocardially and epicardially. And there's essentially no signal in that region. We induced VT, and that's what we saw. We induced a second VT, and that's what we saw. We could actually target that area and move that into the planning system, into the treatment planning system, marry the metabolic information, and treat this patient's VT. Importantly, this is a beautiful picture, but I'm going to actually end on this picture, which is the pastor about a year later who's putting up drywall, no longer getting shocked off antiarrhythmic drugs. So I'm going to stop with the patients. I look forward to a lively discussion here. Thank you for your time.